In this talk, we'll go over many different items that require just a few words on the Baptist health system, including transfers, trauma, rabies, split flow consents, and others. So let's start out with transfers. All transfers in the Baptist system, that's in or out or within, have to go through Access Baptist. So if you need help getting a physician that's not available on the call roster, you go through Access. If you have a trauma patient that needs transfer, you go through Access. If you have an OB patient that needs the OB alert at Mission Trail, you go through Access. If you have a neurointervention alert or an intracranial hemorrhage, or you have a neurosurgical non-traumatic emergency, all of these go through Access Baptist. All transfers must go through Access Baptist. They are a great resource for us and save us lots of time by doing the legwork that we used to have to do ourselves. Here is Access Baptist's algorithm for how they decide where to send the patient. The thing that we need to remember is that we contact them. They will then help us decide whether the patient needs to be MedCom, that's the immediate trauma transfer for shock trauma patients, or whether the patient could go to our level 3 trauma center at North Central Baptist. Sometimes you'll need to speak with the trauma surgeon at North Central to know for sure whether they have the capability or not. For other patients needing transfer, such as if we do not have hand surgery and we need a hand surgeon or oral maxillofacial, Access Baptist will help us find these people. So these are the pre-hospital red-blue criteria used to determine where the patient will be transferred for major trauma. If the patient has one red or two blue on a pre-hospital basis, they should be preferentially transferred to a level 1 trauma center. Now, the Baptist Health System has 4 level 4 trauma centers, but 1 level 3 trauma center at North Central Baptist, which has expanded capability. But looking through these criteria, we do not have a capability to take care of patients with a Glasgow Coma scale lesser than 12. We cannot also not take care of patients with neurologic deficits and trauma. Our amputations proximal to the wrist or ankle, burns that require admission, penetrating head, neck, or torso trauma also cannot go to our level 3 trauma center. So what are some of the capabilities and exclusions for our level 3 trauma center at North Central? Well, starting out with the things that they cannot take in general at North Central are orthopedic injuries that include pelvic acetabular fractures, calcaneal fractures, open pelvic brick fractures, and tibial plateau fractures. However, new trauma orthopedists are being recruited, and you should check with Access Baptist, like you should with all transfers, to see if we now have that capability there. The trauma surgeon should be able to take care of hemodynamically stable patients with liver lacerations, spleen lacerations, kidney injuries, hollow organ injuries, rib fractures with or without hemopneumothorax, and multisystem trauma that is hemodynamically stable. From a neurosurgery side, we have expanding neurosurgery capability at North Central for trauma patients. The patients with stable head injuries, stable skull fractures, stable spinal fractures without spinal injury or nerve injury can be admitted at North Central. Now, this will have to be done after discussion with a neurosurgeon on call at North Central. For amputation of the hand for reimplantation, There's only one group in town that will do these reimplantations. Again, we should go through Access Baptist, and here's the algorithm, which is also available on STRAC. Basically, it's only going to be for patients that have a thumb amputation, if they're a child, or have multiple digits. And again, we go through Access, and they get the consulting hand surgeon for us. Here's the procedure for rabies follow-up. Now, Bexar County does have rabies identified in wild feral animals, including cats and dogs. So if we begin rabies prophylaxis in the ED, if the patient's insured, they can follow up for their subsequent immunizations with Texas Med Clinic. If they're uninsured, have Medicare or Medicaid, they can go to the University Hospital ER and they will refer them to their clinic. If the patient has a primary physician, they can request to give the follow-up vaccinations, and they will get the rabies vaccines from the health department. All animal bites should have an animal bite form filled out online through the animal care services. Here's the link to the web page to report this. Next, let's talk about split flow, which is a process improvement method to try and improve our throughput times for patients. Basically, this means that you don't own your bed when you come to the emergency department, that you will be continually moving through the system. So patients initially are screened either to the acute care or intake and procedures, depending on whether they're going to be admitted likely or not. Patients who are sorted to either the acute care or the procedures area, once it's determined that they likely will not be admitted, will be moved to the results pending area, where they'll be cohorted with other patients that are awaiting results. This frees up the beds for other patients who need initial evaluation and initiation of treatment. A couple words about consent. All informed consent has to be done by the physician providing it. Now, some additional areas where we have to do this are with blood products and if we're going to do a procedural sedation. One of the misconceptions about consents in the system, or in some of the system, is that patients cannot give consent once they've been given pain medication. Well, this is not correct. The policy actually reads for elective patients, their consent should be signed before they're given sedation prior to anesthesia. It does not preclude patients from getting pain medicine, and we should give pain medicine to patients that need it regardless of whether they've signed their consents or not. Currently in the system, all splints have to be applied by a practitioner, a nurse practitioner, a physician's assistant, or a physician. We do not have splint techs at this time, so we'll have to put on our own splints. Hard to code blues. It is a physician judgment to whether it is safe for them to leave the emergency department to respond to a code blue. All physicians by bylaws are required to respond to code blues. We do not respond to off-site MRIs or X-ray. We do not respond to doctors' offices that are connected to the hospital. They should call 911 to have these patients evaluated. We do take care of patients that may be brought to the ED who have coded at an off-site facility, such as somebody that went to an off-site facility for an MRI that was an inpatient and coded while going across the hall to MRI. They may be brought to the ED, but this is rare. Usually they'll be brought to the closest crash cart. We have no obligation to do procedures on the floor or in the units for physicians. We do not respond to Dr. OBs. We don't respond to calls to evaluate non-coding patients on the floor. We should explain to the physicians if they call us asking us to do these things that our primary responsibility is the ED, and we really should not leave the ED to do non-coding procedures on the floor. Talk a little bit about our quality measures and opportunities for improvement. Where will these come from? Well, some of them come from core measure abstractions. They may be a set marker that we track, such as deaths in the EDs. Somebody may do what's called a MIDAS report, and you can do a MIDAS report at any time as well. It is a request to investigate what you believe is a safety matter in the hospital or with another physician. You do this by contacting Access Baptist and saying, I want to do a MIDAS report, and then give them the details of it. Quality assurances may also come from a physician calling the medical director directly. They may come from specific initiatives that we have, such as sepsis or stroke or any new clinical initiative. Our approach to these safety quality issues are that they are multifactorial, and the best solutions generally are system changes to make it easy for the physician to do the right thing and hard for them to do the wrong thing. To do this, your input is very important. So please respond to any letters or emails that you receive from the quality department. Your insight into these cases and what happened and how we can improve it and how you can improve are critical to us making progress. An additional quality safety measure that's available to us through our parent company, the U.S. Acute Care Solutions, is the Fail-Safe program, or this is call a doc for help. What this is specifically for is there's a list of clinical management tools that have been developed by the national team, and we've asked that the physicians follow these. Of course, they can always use their own judgment, but if they're thinking of doing something different and they have a reason and they want to talk with somebody about it, that they can call and talk with an experienced physician, emergency physician at this. For example, you have somebody with testicular pain, that you should get an ultrasound or have a urologist evaluate the patient. But maybe there's something else that you're thinking that's different about this patient. There's somebody that you could, and you don't want to do that. There's a physician on call that you can call, and they'll call you back in a few minutes and talk it over with you. Okay, let's talk a little bit about fixing other people's script problems. So we get calls from pharmacies all the time saying that either the dose doesn't exist anymore, or can they change it to a generic, and we should try and solve these script problems for each other. However, if it's against your medical advice, if they gave them 100 Valium or something, I mean, you don't have to do that. But in general, we should be supporting each other so that we can fix these script problems and keep our patients happy. You can make a brief addendum in the patient's chart once you've called in this change in prescription. Please note that hydrocodone is now Schedule 3 in Texas and requires special script pads. So you cannot just write a regular script for hydrocodone. Okay, how about psychiatric patients? Now this shows that less than 56 years of age psychiatric algorithm, but our algorithm really is for all psychiatric patients. 56 just lets you know that if they're over 56, they could go to the geriatric psych unit. So if we determine that the patient needs a psychiatric admission, we call our behavioral assessment team, who will come and evaluate the patient. Generally, they're going to want alcohol levels, urine drug screens, CBC, CMP, urinalysis. If they're a geriatric patient, they're going to want a chest x-ray as well and an EKG. We do not need to wait for these to be back to call for the behavioral assessment team to come. If the patient is funded and there's a bed available at Baptist Medical Center downtown, then the BAT team will arrange a doc-to-doc conversation so we can transfer them to BMC. The patient is uninsured and it's determined that they need to be admitted and are medically stable, there is something called the MCOT, MCOT beds. These are state-funded beds available for indigent patients needing psychiatric care. This requires a separate evaluation by the MCOT reviewer after the behavioral assessment team. And unfortunately, this can take hours to days for them to come. If the patients have to stay in the ED awaiting the MCOT evaluation or bed placement, we should periodically reassess these patients. At a minimum, at each shift turnover, we should go see the patient, evaluate them, and write a brief note. Another item, documentation of X-ray interpretations. If we see a plain film and make a disposition based on it prior to the radiologist reading it, we need to do a preliminary in PACS. This lets the radiologist know what our preliminary thinking was and whether it forces them to either agree or disagree with us. If they disagree with us, they will contact the ED so we can follow up with the patient. We do not do preliminary interpretations of CT, MRI, or of formal ultrasound. We can do bedside ultrasound and document it. Radiologists are available 24 hours a day, 7 days a week. However, at St. Luke's, they do not interpret plain films at night, so it's very important that at St. Luke's at night we do our own preliminary interpretations. Another item is cultures, DNA probes, flu, and RSV screens. Please limit the use of these since each wound or urine culture has to be followed up for the culture to see what happens to the patient. This is very labor intensive. If a patient has an indication for these, of course you should do them. But most abscesses that are discharged home don't need a wound culture. The same for simple bacterial cystitis in a young woman. These don't need urine cultures. If you obtain a GC and chlamydia DNA probe, make sure that you either treat the patient or wait for the result to come back. These are all done at North Central Baptist and require it to be transferred to that hospital to be done, which can take a long time to get back. So again, if you're going to obtain these, either treat or wait for the results to come back before dispositioning the patient. Another item that I'd like to ask is that you not do throat cultures, that you use the Centaur criteria instead. And this applies also to rapid strep screens. Strep throat is basically a self-limited illness. And so I would recommend that you either treat or not treat, because if you decide based on a negative strep screen that the patient doesn't have it and discharge them home, a culture may later find it, and then somebody else is going to have to follow up on that. And then for flu and RSV screens, for patient care and patient flow, I'd also ask that you limit the use of these. The flu screen is not as good as clinical judgment when there's a flu epidemic going on. If the prevalence of the disease is extremely low, such as not at flu season, the false positive rate may be as high as 95% and lead you down the wrong path as to the etiology of this patient's symptoms. The sensitivity of the test, according to the CDC, is only 50 to 70%. So again, not a great test for flu. And there is no real treatment that works for the flu. And it takes time to do these and to send them back. Also recommend that you not obtain RSV screens unless you feel the patient's going to be admitted. Since there is no therapy specific therapy for RSV. It's only really useful for cohorting admitted patients. Let's talk about Foley catheters. Uh, Catheter-associated urinary tract infections is a nationally reported metric, and we want to prevent our patients from getting these infections. The best way to do this is to limit our use to patients that really need it, and then following the Foley catheter bundle. So in our EDs, no patient should have a catheter unless there's a prior physician order for it. There should not be a time when a nurse says, "Doctor, I put in a Foley, can you go ahead and put the order in?" It should only be with a physician order, and it has to be for an appropriate reason. The order will force you to document the reason. One reason may be that they're critically ill and need to monitor their output. If they have bladder outlet obstruction, if the patient has a sacral wound that's open, if they are requiring prolonged immobilization. And an additional one is if they have a hip fracture, they can go ahead and get a Foley catheter for their comfort. So what are some of the inappropriate reasons for getting a Foley catheter? Well, they're demented or they're confused. Or if you just want to get a urine specimen. If you need a specimen and they can't provide it, you can do an in and out, which is okay. It should not be placed for just incontinence unless they have something such as an open wound. It shouldn't be placed for morbid obesity. It shouldn't be done for the healthcare worker's convenience, such as, "I gave them Lasix, let's put in a Foley." And it should not be for the patient's request. If the patient just requests it but they don't have another reason, we should not be placing a Foley. All catheter-associated urinary tract infections where the patient had a Foley placed in the ED will be reviewed by the emergency department quality committee, and if there's opportunities for improvement, they will be communicated to the physician. So let's talk about central line placement and central line infection. The Baptist Health System has mandated that all central lines be placed with a bundle. So that includes hand hygiene, with hand washing and no jewelry, full barrier protection for both the provider placing the line and the patient, chlorhexidine prep, subclavian or internal jugular as a preferred place. If you must use a femoral, you should document the reason why it was used. Again, all femoral lines will be audited for reason and opportunities for the physician if they exist. Now, a truly emergent central line, such as you have CPR in progress, does not have to follow the central line bundle. All others should have the full central line bundle done. A few items about the central line associated infections. These also are national quality metric with big consequences for our patients. Now, in making the diagnosis, we should not draw cultures from the central line to diagnose central line infection. You can get blood cultures from a newly placed central line that you put in right now, but if you're trying to establish the source of an infection, you should not draw blood cultures from the central line. Also, do not remove central lines for presumed central line infection unless there's gross infection at the site. Blood cultures should be obtained from fresh venipunctures peripherally, and at least 2 blood cultures should be obtained. The diagnosis of central line associated infection is finding an organism and no other source for the infection, with the presumed etiology being the central line. And this is not something we're going to be doing in the emergency department. So do not draw blood cultures from already established central lines. And don't remove central lines to culture the tip unless there is frank infection at the site of insertion. Now a brief patient satisfaction item. We use something called AID it, which is we acknowledge, introduce, give a duration of expected care, explanation of what's going on, and then thank the patient. AID it helps us to have a better experience for our patients, and if our patients have a better experience, we'll have a better experience also. So we acknowledge the patient. So when we come in, we greet the person by name, we make eye contact, we acknowledge any family members or friends that are in the room. Then we introduce ourselves. We say who we are. Say, I'm the doctor, and I'm an emergency physician. I'll be taking care of you today. After you've examined the patient and talked with them, you should give them a duration, how long it's going to take. You should try and overestimate how long it's going to take and give them some explanation for what the steps are going to be and what's going to happen. The nurse is going to come in and she's going to talk with you. She's going to draw blood and they're going to get an IV and they're going to give you some pain medicine. You're going to go to x-ray and just explain to them how it works. And then when it all comes back and everything's ready and you're ready to disposition the patient, you should have another discussion with the patient, and then you should thank the patient for letting us take care of them. This really does improve the patient experience, and if any of you have ever been a patient in a hospital, these items are, you'll agree, are key. One last item is residents. At Northeast Baptist, we have third-year residents from UT Health Science Center, San Antonio. They're third-year residents, and they should be given quite a bit of autonomy. We still have to be present for key elements such as central line placement or intubation, but in general, these residents should be allowed to see and work up patients. We'll need to see every one of these patients with them, and we can either sign their note by having them forward it to us, or we can do a brief addendum saying that we've seen the patient with them.